Representative Paré.
Good morning, Secretary Cohen. Thank you for being here. It's a pleasure to be able to speak to you today, and I appreciate all three of you, Secretary Sanders and Mr. Lilly, for being here to answer my questions. I found your presentations to be interesting and informative, so thank you. Just a few, if it's okay for a line of questioning, Chair.
Yes.
Okay.
You recognize for a series of questions.
Throughout the pandemic, this is for Secretary Cohen, you and Governor Cooper said that science and data were driving policy decisions. And I think it's important that the people of North Carolina have confidence in the science and the data. But this morning, you acknowledged multiple challenges with data collection and reporting along the way. Not in your presentation, but also true that North Carolina has been one of the slowest states to report death data to the CDC. UNC's Zainab Tufekci and former FDA Commissioner Scott Gottlieb, among others, have criticized the lack of reliable COVID data across the country and not just in North Carolina. My question is for you to speak on the tendency for public health officials to consistently overstate the reliability of the data when making pronouncements, and even when those pronouncements seem to contradict previous recommendations.
Well, thank you, Representative. You will note that in no press conference I have given have I ever said that we are using death data to drive decision making, and that was really intentional because we knew we had data lags around death. We are one of only 2 states as we went into this pandemic that did not have an electronic death data capacity. That was something that we did not have going into this, and so we definitely built up our data capability. And actually, starting in January, we have, and Representative Bowles knows this very well, we are moving to that electronic reporting beginning in January. And thank you to the General Assembly for the support and obviously the funding to be able to do that. But it's not something we had going into the early part of this pandemic. So when I looked at the 4 pieces of data that I did at those press conference, it was cases, percent of tests that were positive, our hospitalization, and our surveillance data. That I felt very good about the kinds of data that we have. And in fact, we've won many awards for our data quality and have frankly taught a lot of states about how we've done our data collection. At first, it was very manual, so it means I had to put a lot of people on it, but I still felt good about the data we had. What we've been able to do now is automate that data or maybe make it electronically reported so I can move those folks in to do other work. But I had confidence in the quality and the accuracy of the data. It was just a very, very, very labor-intensive process at first that we've been able to automate over time. But the death data has certainly been a place that has lagged in terms of data. Now we are getting data within a week. So if someone dies of COVID, we do get that data now within a week.
Follow up on that, though, the sort of the second part of my question. I guess I'm curious, are you concerned about the public's, hesitation to believe the data as it's changed over time, and that the recommendations that you're making is based on data that maybe has changed over time, but maybe has resulted in not being exactly what we thought it was at the beginning? I mean, how do we get over that hurdle of people having confidence in the science and the data that public health officials are coming out with, and therefore their recommendations based on that?
Sure. No, I appreciate that, and I think folks are learning a lot more about the scientific process, and it means at some part, and I shared this in my earlier presentation, there were things we didn't know about COVID and how strong it was, how was it exactly spread, and it was things we needed to learn over time. What I've tried to do as I led this response and would talk to you all and the press frequently was to try to be clear of what we did know and what we didn't know, to show what were the things we were looking at to make decisions, right? What metrics were we looking at? Is all data perfect? No, we know it isn't, but we have to move forward and use make good decisions based on the data that we have. And what I've tried to do is explain to folks what we know, what we don't know, why we know it, and recognize that we're going to learn things in the future. And we have. We've learned more about COVID. We've learned more about how to prevent it. And I can be more and more confident about the things that we say, given that learning. It's just as I was answering the last question about Omicron variant. We don't know yet exactly what this will mean. And it doesn't mean that our scientists aren't smart or the data's not good. Sometimes it just takes time for us to learn those lessons. And I'm hoping the people of North Carolina have appreciated our transparency and not trying to overstate what we don't know. And hopefully that has built trust with folks.
I'd like to ask a question, and I wasn't planning to ask this question, but listening to your presentation, I was a little bit curious about if you can clarify something for me. So I understand, and as you stated, I believe you said this, so correct me if I'm wrong, that hospitalizations, we were worried early on about capacity, and that capacity problem wasn't as bad as I guess we were thinking it could be. So we had some openings in our hospitals, and I think you said that we brought in some patients from other states to fill those openings. There are a lot of people that were told it's a good idea to not seek elective surgeries and elective health care because of the hospital capacity problem that never ended up being what we thought it was, as bad as we thought it was going to be. So if you're bringing in patients from other states to treat them in empty hospital beds, and we're talking about long-term health impacts as a result of COVID, you would have to consider that asking people, or forcing people, I guess, to put off elective surgeries has created other health problems as a result of putting that off. So how do you reconcile that decision to ask people to put off surgeries that they needed for their general health out of fear of a COVID capacity hospital problem that didn't materialize the way we thought it would, and then bringing in patients from other states?
I'm really glad you asked this question, Representative, because this is just a matter of timing. The only time that we had asked hospitals to put off non-emergent procedures was right in the beginning, when we didn't know how fast was this coming, what was the capacity needs of our state. We were not taking patients from out of state at that time at all, because we didn't know what we didn't know. And that window was a very short period of time. For very much the point you're making, we know, and I think Senator Johnson made this as well, there are other important health considerations that we absolutely were thinking about. So we really tried to make sure that that time frame was as short as possible. And now that, for the vast majority of the pandemic, that has not been something that we have needed to ask of the hospitals. And what they would say if they were sitting here is that they have built up their capabilities to handle COVID and be able to handle their elective surgery load as well. So even when we were in this summer, when we were at, as I was saying, some of the highest COVID hospitalizations that we were seeing, the most number of people in the intensive care units, we did not need to have hospitals reduce their knee replacements or their hip replacement, right? They were able to keep that up, but it took a lot of hard work to get us to a place to be able to do that, to be able to maintain all of the kinds of healthcare services that were needed to be delivered and still take on that enormous load of COVID. So I commend them from that work. So just know those were different periods of time that I was talking about. Frankly, it was almost a year later.
Do we have numbers that would quantify the outcome of asking people to put off those general health surgeries or treatments at hospitals? Do we have any data on what the effect of that has been?
Well, I think it's a good question. I think that, again, because we were able to limit that to a short period of time, the hospitals were able to do some catch up, and they would say they were very, they got pretty busy to catch up on those things, but I think that is probably something better that they could answer. What we would say is, as we look at our overall health statistics for North Carolina, certainly the biggest impact to health that we have seen has obviously been COVID, the thing that is killing more people than, Mr. Lilly shared some of that data in terms of it being the highest cause of death across the United States is COVID. So it has obviously certainly been the center of our attention.
I'd like to ask you a little bit another public health question. You have stated that underinvestment in public health has been a challenge to overcome. In a normal year, food programs for women and children are 40% or more of the $700+ million in spending at the Division of Public Health. Adding in other women's and children's health issues, sickle cell and HIV, TB, brings us up to 80% of total spending in the Division of Public Health. So I'd like you to speak, please, to what is the core function of public health and how should it be organized and funded?
Wow, that's a big question. I really appreciate that. And it's probably something I need to do a bit more thinking about in terms of what is the right go forward in terms of funding. You know, a lot of the funding you just mentioned about public health, particularly the women, infant, children, like that's all federal dollars, which means we don't have a lot to say, well, let's not spend that $40 million over here, let's spend it over there. We don't have the choice to do that. Mm-hmm. So I think the question is, what are the capabilities of public health that we need to make sure are there as we both continue to respond, but also to make sure we're going to prevent the next pandemic, and God forbid it happens, that we can respond to it again. I will definitely say that we are going to need that continued investment in data systems, the surveillance, the early identification pieces, because if we can early identify things, we can jump on it and hopefully it not become a big issue. So I do think the surveillance and the data systems are for sure important. The other big thing that I would talk about related to public health funding is thinking about what are the ways in which we can both have core public health expertise, but we're going to need to cross-train people, right? We're never going to have the capacity to respond to this global pandemic all the time, right? That's you have to shrink it down. But I think what we need to be doing better is making sure folks are ready to respond if that would happen, meaning cross-train all the time. And what I would say, Representative Paré, if I could come back to you, and the team is doing some thinking about what does it take to fund public health, what should that really look like going forward into the future. And like I said, some of that is not to say I don't think we should spend it on women and children. And again, that's a federal program where we don't have a lot of flexibility. It's a matter of, okay, in the communicable disease space, like what is it that we need to be doing? And I'd love to come back to you, and I really appreciate that window of opportunity. Thank you.